Stan asked me to share some of my knowledge of neurology with you. It is not as inspiring as the last three speakers that were up here, so I will try not to be too dry. But I think there's a real value in reminding yourself of what you learned in school with neurology and to try and implement it with your patients, because ultimately what you're trying to do is objectify your care so that you can provide a better service. And what we learned in school with our classic neurology exam can be very valuable to the upper cervical practitioner, because ultimately your goal is to identify if a subluxation or if a misalignment is creating a neurological sequelae in the patient. And if you don't look, you will not see. And when you change the way you look at something, what you look at will change. So I would challenge you to start to look at your patients in a different way. I know many of you are into looking at imaging, x-rays, CT scans, and things of that nature, identifying malalignment, malpositioning. But what are you doing to identify the neurological imbalances that are a consequence of that? And what are you doing to identify the changes that you've made in that patient? So if you don't look, you won't be able to share that with the patient, number one. And I think there's a lot of value in understanding what is actually happening neurologically with your patient. So as Dr. Stan said, I taught the upper cervical diplomate neurology portion, and that was challenging because ultimately the practitioners there wanted to know what happens when there's a subluxation, how can we identify that subluxation is there, and really I felt that there was an expectation that I would spoon feed that to the group. And I didn't want to do that. And I told them before I even took the job, I'm not going to sit up there and just tell them this is why what you do works. What I wanted to do was teach them neurology, and then they tell me why what they do works. We're all doctors. We're all primary care providers. I wanted to give them the knowledge or share the knowledge that I had so that they could become better doctors and ultimately lift the profession up. Not that I would just spoon feed to you, okay, this is what happens when there's dentate ligament distortion, and these are the patterns of dysfunction that you'll see. I felt that that would create a bit of a disservice to the profession, and I thought that the upper cervical diplomate was really designed to raise up the profession. So that's what I did, and unfortunately, I don't know that it went over too well because I didn't get invited back. So, so that was that. But I have I
like the doctor.
Yeah, you like it. Ian was there. I was trained as an upper cervical doctor. I was a knee chest provider for the first 5 years of practice. And then, just a little background on me, and then I found the Neurodiplomate program. I went through the Neurodiplomate program, and that really changed the way that I looked at patients, and I think for the better. And then, after about 10 years of practice, I met Gary Deutschman, who you just heard speak. Gary was dealing with scoliosis patients at the time, and we started to look at our scoliosis patients, or his scoliosis patients at that time, as if they had a movement disorder. And so we really took the structural imbalance and tied it to what's happening neurologically in these patients and what can we do from a neurological standpoint to make change. And really from there our practice grew, and we created the Scoli Fit program. And scoliosis was a great niche for us, and it really took over both of our lives. And I kind of got away from the neurology side of it for a few years, and then over time it's really my passion, so I've gotten back into studying. And I think that some of the things that I'll show you today, and I'll speak to you again for another session about neurology, are some of it will be review, and some of it I'm just going to try and remind you of how important it is for you to use what you already know. And then I'm also going to teach you about some things that are probably haven't heard of yet, and really things that should turn chiropractic on its ear and should change the way we all practice. And so hopefully I'll share that with you over the next 2 hours that I'm with you, and hopefully that'll spark some new interest on those fronts. So how can we understand neurology, and how can that change the way we look at our patients? So I found this image. Where's the subluxation here? And what correction would you recommend in a case like this? And is it possible that there's a neurological imbalance that this patient is experiencing? So it's a little bit tongue-in-cheek, but that's probably the way the neuroscience or the neurosurgeons would try to manage upper cervical subluxation. That is correct. That is a screw going right through the odontoid process. So what are the concepts or the theories of neurological sequelae associated with the upper cervical subluxation? I put down 7 of them here that I think pertain to your practice. Number 1 is brainstem tension or brainstem compression. And when I was training in upper cervical, many of the practitioners at that time called themselves brainstem specialists. And I always took that with a bit of offense, because many of the people I was working with had really no intimate understanding of the brainstem. And so I felt that if I was going to call myself a brainstem specialist, I ought to know about the brainstem in an intimate way, and I ought to be an expert in the brainstem. And so Sean and I actually went to school together, and I'll still remember to this day, we had a conversation that we have to know what the neurosurgeons know about the nervous system in order to be experts in managing upper cervical subluxation. So I took that upon myself over the years to try and become an expert in understanding what signs and symptoms will be present when the brainstem is compressed. And so I'm sure the students kind of have this fresh on their minds and the doctors don't. And it's important for us to know what a brainstem presentation will look like. Okay, and we'll talk about that. Number 2, genetic bone asymmetry and resultant disafferentation. In upper cervical care, you talk about genetic imbalances in the way the bones are formed. And when there is a genetic imbalance, that'll change the movement patterns of that patient. And that will ultimately change the afferent drive to the higher cortical centers. So even if you had someone with a screw going up through their odontoid and limiting movement in that area, that will have some sort of neurological consequence over time because of that. If you have patients that have asymmetries of condyles or asymmetrical foramen magnums, that in itself will have some effect neurologically. And understanding that is important because some of that you cannot change. Number 3, muscle spindle dysfunction and its central connections. The upper cervical spine, when you look at it on an X-ray, you do not see muscle. You are inferring, when you see a subluxation pattern on an X-ray, that there must be some imbalance in the muscles that connect to those bony prominences, correct? And all of those bony prominences are, in fact, connection points of muscle. So the muscle spindle afferents from the upper cervical spine are very, very important in your work, and I don't hear much of that being talked about in your teachings or in your analysis. And I think you should really consider that those upper cervical suboccipital muscles are actually proprioceptive receptors. They don't work as muscles in the classical sense to create rotation. Is there a lot of rotation between atlas and occiput? But there are muscles there. So there are muscles that connect that are really receptors that are designed to feed information to the higher cortical centers. And you're going to hear today about some of those higher cortical centers. Has anyone ever heard of head direction cells? Raise of hands if you've heard of a head direction cell. No. So these are really new ideas that should change the way we practice and should change the way we understand what we're doing. And those muscle spindle receptors and that suboccipital triangle and those obliquus capitis muscles and all the fancy European named muscles in the upper cervical spine, these are receptor systems that drive to the higher cortical centers that you need to be aware of. Joint mechanoreceptor number 4, disafferentation. Of course, this is one that rings true to most of us because we're looking at joints. So we figure it must be joint mechanoreceptors that are driving disafferentation, and that is true, but if you read the literature, it's true to a lesser extent than the muscle spindle systems. And so, again, rethinking how we identify subluxation and understanding what subluxation causes centrally, I think should be part of the conversation. Number 5, the head direction cell network. There are a network of cells throughout the neuraxis that start in the thalamus and go through to the hippocampus and then all the way up to the insular cortex, parietal lobe, that are all concerned with the direction of your head. Okay, there's the head direction cell network, and when there are afferent imbalances, whether we're talking about subluxation at the upper cervical spine, loss of the cervical curve, injury, loss of dorsal column function. All of those systems drive centrally and are used to create a representation of your body in space. And they are also used to create alignment of your body with gravity and with the horizon. If there are imbalances in any one of those receptor systems, the central neurological consequence is that the head direction cell network will become disturbed. So if you take your patient and you say, close your eyes, turn your head left, turn your head right, go ahead and hold yourself in a orthogonal position, or as close to an orthogonal position as you can put it, and it is not perfectly orthogonal, well, you're either dealing with some sort of asymmetry of bone, like a genetic variant, or you're dealing with an imbalance in this head direction cell network. That is tremendous for the upper cervical doctor to understand, because ultimately, when you make an adjustment or when you make some sort of intervention that changes that patient's ability to align their head orthogonally, then you've changed those higher cortical centers. You've changed the head direction cell network sufficiently enough that they're now capable of aligning their head in a more aligned position. So I know that's not exactly what a subluxation is, but it's obviously related to it. Number 6 are reflexogenic abnormalities. Our ability to hold ourselves upright in gravity does not come from our conscious control of posture. It comes from the reflexogenic systems. These are graviceptive systems that are activated by gravity and create tone in muscle. So the reason I'm able to hold myself upright in gravity with my head over my sternum is because my graviceptive systems, reflexogenic systems of posture have enough integrity to hold me up. If I hold myself up and I have asymmetries of that righting reflex, those are things that can change. We can create changes in those reflexes, but understanding how those reflexes integrate and how you as a chiropractor are going to intervene are also very, very important. Number 7 is nerve root irritation and influence of the cervical ganglia, and those are simple ideas that most of us learn early on about compression of nerves and the effects of dystally that come with that. Interesting science that's out there. This is from 1958. Has anyone ever seen this article or know of its existence? Foramen magnum and high cervical syndromes. This was published in 1958. I have the paper here. I'll share it with you. And basically what they found was that there are upper cervical imbalances that cause brainstem syndromes. And it's an old article, so I didn't put it in the presentation. But then I found some more articles that talked about foramen magnum meningiomas, so tumors in the foramen magnum that again create brainstem syndromes and cerebellar syndromes. So if you're dealing with a patient that has an upper cervical subluxation and it is significant enough to affect the brainstem or cerebellum, you should be able to elicit and find those imbalances through your exam. And so understanding what those imbalances will look like are going to make you a better practitioner, I think, at some level. And ultimately, I think will help the profession maintain its ability to keep seeing patients. One of the problems that I have with our profession is we don't always speak the same language as the other professions, and therefore they don't know if what we're saying makes any sense. So I believe that if we speak their language, doesn't mean we have to give up our language, but we should speak two languages. We should understand what a neurological imbalance looks like to a neuroscientist and be able to translate that or translate what we see in upper cervical imbalances into that language. So this science is there for you to see, and ultimately if you believe that there is an upper cervical subluxation, you should be able to elicit some of these imbalances. So just going back to your exam as a student, we look at the lateral medullary syndrome, which is usually a consequence of a stroke, but also can be a consequence of compression of the medulla. We see symptoms, general symptoms of dizziness, vertigo, falling or veering when the eyes are closed. If it's a bleed, if it's an actual ablative lesion, then you would see falling when the eyes are open as well. But in order to elicit a softer lesion, an imbalance that might be there from a mild compression, have your patients close their eyes and you'll see that they'll fall to or lean to a side or create sway to a side. Difficulty sitting without a support, dysphagia, and diplopia. So diplopia, for example, if you have patients that when they fatigue, their eyes tend to cross, so they have complaints that, yeah, as I get tired at the end of the day, sometimes I'll get some difficulty to, hold my vision with vergence. These are soft signs that, as upper cervical chiropractors, you should be putting in the patient note. And then when you intervene, if those signs and symptoms resolve, that's part of the patient getting better. And I think that those soft lesions sometimes just get glossed over. The important thing to know about brainstem syndromes is that you will get a crossed chord pattern or a crossing pattern. There'll be ipsilateral findings in the face, and there'll be contralateral findings in the long tracts. Ipsilateral face, contralateral long tracts. So that means if you go back to your cranial nerve exam and you check sensation over V1, V2, and V3, or you check for the corneal reflex, and you see that there's some imbalance, either in pain and temperature from one side of the face to the other, take that as an imbalance. Take that as a neurological sign. How many times, I don't know if you guys do this in your practice, but take something cold, right? Remember this? Take one of these, put it on the face. Does this feel the same as this? Oh, it feels a little colder on this side. That's a sign of a neurological imbalance. It gets glossed over every day. Number one, many of you may not be doing it. Number two, if you see it, it means something. Same thing when you check a deep tendon reflex. If you can't elicit a deep tendon reflex, it means something. It means that the tone of that muscle is not appropriate. It means that the receptors that you're activating when you whack that tendon, you create that stretch, the gain is not set appropriately. That means something. So I just want you to remind yourself of the things you already know. Ipsilateral signs in a medullary syndrome, and we can look to the stroke literature because that will give us lots of good information. Loss of pain and temperature in the face, so take your pinwheel or prick the face on either side and see if it's not symmetrical. Horner syndrome is ptosis of the eyelid, a change in the shape of the pupil, and potentially a change in the way the patient's sweating on the face. Looking at the palate, paralysis of the palate. So take your popsicle stick, stick it out their tongue, have them say ah, get your torch, look at the back of that palate and see if the palate rises equally. If it doesn't, it's a sign of neurological imbalance. It's a sign of a brainstem disafferentation, or I should say, not disafferentation, but a sign of the output of the brainstem nuclei not being balanced. Ask your patients if they have difficulty swallowing, if they get a hoarse voice, if they wake up with their voices hoarse, and then looking for nystagmus would be something a little more advanced. And I brought my VNG equipment, so when I set up for us next time, we'll actually look at some vestibular and oculomotor reflexes. We'll look for nystagmus. And I think that's another really interesting way to assess brainstem function. The contralateral signs, the long track signs, will be loss of pain and temperature, sensation on the trunk and the limbs on the opposite side of the face loss. Not on here, but pyramidal weakness would be another one that you find. So you'd see extensor weakness opposite the side of the signs on the face. So we check extensors by having patients spread their hands and squeeze to see if the tone is equal on both sides. We could check dorsiflexion of the foot and check the ability of the patient to resist against your pressure. We can look at the big toe and see if the great toe has some weaknesses. So brainstem syndromes, I think, would be really important for the upper cervical doctor to be an expert in, to understand what nuclei live in the brainstem, what long tracts pass through on that same side. We know the long tracts, whether they're sensory or motor, come down and cross over, and so we would see this crossed pattern. So these are things that we all learned and all know, but maybe don't use on a daily basis. And this is a cross-section through the medulla, and all these wonderful things live in there. We see the inferior olive. This is basically our ability to connect to our cerebellum. The inferior olive sends mossy fibers and climbing fibers right up to the cerebellum. So when you have a patient, let's say, who has a cerebellar sign, this is another important thing for you to look at, and you see that change. So what's a cerebellar sign? How about finger to nose, right? They try and then they miss with one hand. That indicates maybe an inability to understand the angulation of their joints or to know where they are in space. And then the next time they connect, that tells you, not that there wasn't a problem, it tells you that they were able to motor learn, but that first pass does tell you that the connections were not what they should be between that brainstem and the cerebellum. So understanding blood supply to the brain and understanding that subluxation may influence these vessels as well can help you to start to identify brainstem imbalances related to subluxation. Again, looking at the the cross patterns, ipsilateral face, contralateral body. I don't want to get into the tracks with you, but those long tracks are either ascending, they're sensory, or they're descending in their motor. And if there is cord tension, brainstem tension, or some sort of tension pulling down on the cerebellum, there's going to be a consequence. You should be trying to elicit and find that consequence, because when you intervene and change it, then you can speak in the language of the other healthcare professionals in your community. And when you have a patient that had a clonus, who knows what a clonus is? Clonus is a motor sign that indicates a loss of inhibition to the motor tracts. And you intervene and you change. If you send that patient report to their medical doctor and say they had a subluxation which is corrected, that's not their language. But if you say they had a subluxation which had a consequence of clonus, which is now no longer elicitable, that is speaking their language. I think that raises the whole profession.
Tell about the clonus, that case in Dubai.
If Gary wants me to share one case where we did this. A patient came to us, it was a scoliosis patient, and we were seeing the patient, I think, in Saudi Arabia. Anyway.
Oh yeah, Saudi, that's right.
Is it fully covered or is it kind of covered?
Yeah. The patient had a clonus on ankle jerk, so created a forced dorsiflexion of the foot, created a non-fatigable clonus where the
Foot.
flexor muscles of the foot continued to fire. Gary adjusted the patient. I went back to sleep because I didn't adjust to the time frame.
No, but the best part, the neurologist from the hospital, the head of neurology, was with you when you were doing the exam.
I was barely awake.
So he saw the non-fatigable clonus, which doesn't go away. It's a, okay.
Well, it's a neurological sign of an upper motor neuron lesion. And so Gary adjusted the patient. They woke me back up to come and re-examine the patient. I re-examined, and the clonus was gone. So if we didn't look, we wouldn't have seen. If we didn't see, we couldn't have reported. And hopefully that changed that doctor's mind and obviously changed the life of that patient. So these are just some of the things that you look for in your exam. Look for the dissociative symptoms of pain and temperature on the face and the long track signs on the body. Look at dorsal column function, 2-point discrimination. So if you don't remember, I brought all my tools here. We can talk about it, but basically you take 2 pins, you touch the patient, and you ask them if they feel 1 prick or 2, and you see if that's similar on one side of the body to the other. And you may find that patients may have loss of 2-point discrimination on one side versus the other. These are going to be ipsilateral findings. They're going to be, or I should say, unilateral findings. And so you've got to test both sides of the body and joint position sense. When you're looking at upper cervical subluxation, you're looking to some degree at the patient's ability to right their head in gravity. When you have a patient sit in front of an x-ray machine, if their head is tilted and rotated, there may be a bony lock there, but more likely it's a consequence of a disturbance in the patient's ability to find neutral with their head. And again, that speaks about those head direction cells, which really should change chiropractic altogether as we learn more about them. So look at the patient's ability to angulate their joints. Vibration sense, taking a tuning fork, wagging it, touching it to the knee, see if they feel it, touch it to the other side, see if it feels the same. Do it onto the thumbs. Looking at stretch reflexes, so deep tendon reflexes. I can't tell you how many patients come into me and have no reflexes that are elicitable or have hyperreflexia. And I say, has anyone ever seen this before? Oh yeah, all my doctors have seen it. And what have they said? Nothing. Because they don't really understand that that's a window into the tone of that person's central nervous system. I want upper cervical doctors to know that. Pathological reflexes, so important for you to be able to elicit and identify pathological reflexes. Babinski's sign, scraping at the bottom of the toe. Looking at superficial abdominal reflexes in appropriate patients. If you're dealing with patients that have had children, they may lose those reflexes. But these are important reflexes to identify and understand if they're there. Looking at the ability of the patient to right themselves in gravity. Look at their sway patterns in gravity. There are more advanced ways of looking at that, like computerized dynamic posturography, but you can simply do it by having the patient close their eyes. You can have them close their eyes and try and march in place. If they march in a rotating fashion, that's an indication that their sense of where they are in space is disturbed, and it's indicating to you that there's an imbalance in those writing reflexes. If you intervene, now I don't expect you to retrain them to walk in a more appropriate manner. You're going to intervene as an upper cervical chiropractor. And then if you change that, the outcome changes on that test, report that and make that part of your report of findings with the patient. Part of your outcome assessment is you normalize an abnormal reflex. The profession will rise up the more we do this. Going back to your cranial nerve exam, so important. Where do the cranial nerves live? Most of them in the brainstem. So your cranial nerve 1, the optic, or olfactory, 2, optic. Those two, okay, you're looking at the higher cortical brain. But cranial nerve 3, 4, 6, and 12, right? So the muscles, the cranial nerves that move the muscles of the eyes and the tongue, you should be assessing that. We, in the upper cervical training, in the neurological training that I took, we had a saying, 3, 4, 6, and 12, eyes and spine. They are intimately connected. If you've got imbalances in the recti muscles of the neck, the scalene muscles of the neck, you're going to have imbalances in the oculomotor muscles as well. They are born of the same embryological tissue. They are under the same neurological influences. So look at these cranial nerve functions. Look at the patient's ability to smooth pursue with their eyes. That's cranial nerve 3 and 6, right? Cranial nerves 4 as well. If you have them track towards the nose and then down, there's ways for you to look at this. I have all of this. I don't have 24 hours to teach you. I have 2 hours. All of this is in my Prezi notes. They are available to you online. You just Google Prezi and Marc Lamantia. Prezi's Prezi, and all of my study guides are on there. So you can go through and look how to look at the cranial nerve function. Cranial nerves 9, 10, and 11. These are the muscles that are responsible for the gag reflex, right? That are responsible for the trapezius innervation from the brainstem. When was the last time you tried to elicit a gag reflex in your patient? If you believe they've got upper cervical imbalance and you haven't checked their gag reflex, you're remiss. You're remiss. You've got to check it. Cranial nerve 9 gives the sensory input in. Cranial nerve 10 gives the motor output out. Stick your tongue depressor a little deeper than they want. If they don't choke, then they don't have a gag reflex. You can also ask them if, when they brush their teeth, they get a gag reflex if you don't want to offend them. But you should be looking at these reflexes. Cranial nerves are so important. The cerebellum, another part of our nervous system. When someone has a cerebellar imbalance, will they have weakness? No. Cerebellum does not control our tone. It controls our coordination. So if you see someone who's got weakness, you're thinking that maybe they've got a nerve root compression, maybe they've got a pyramidal sign of weakness coming from the higher cortical brain, like the pyramids that cross over, that's the cortical spinal tracts. So if you check for weakness, you're looking for higher cortical function or nerve root. But if they've got incoordination, that's the cerebellum. The cerebellum has 3 distinct regions. One is called the spinocerebellum. What do you think that sets the tone for? the trunk muscles. So we can look and see if there's imbalances in these different regions by just compartmentalizing the cerebellum into its three parts: the spinocerebellum, the vestibulocerebellum. This is responsible for our writing reflex and also our eye movements, or reflexive eye movements, which I'm going to show you next time I get a chance. And then our ability to coordinate movement. So what are some of the cerebellar tests that you remember from school? How about finger to nose? Okay. How about heel to shin? How about dystiodocokinesia, the ability to rapidly alternate movements, right? The ability to hold end gaze. When we all go out tonight to the bar and we have a few pops, and we can check each other for end gaze nystagmus. Why would we get end gaze nystagmus after drinking alcohol? Because alcohol depresses the cerebellum. Why don't they want you driving a car after you've had alcohol? Because alcohol depresses the cerebellum. So if you're assessing these things in your patients that don't have alcohol in their system, you're identifying a cerebellar imbalance. And then when you intervene, and all of you intervene in a different way, but if you intervene and that changes, you've changed the tone of the cerebellum, you've changed that patient's life. Super, super important. Head direction abnormalities. Understanding the systems that feed into this head direction cell network, it should change your confidence in how important what you're doing is. So let me find my head direction. How much time do I have?
15 minutes, 14.
Okay. So this is Prezi, and then you could just go and look at all my different presentations in here. And there's one called Chalkboard Neurology, and that's all the exam stuff. How to do cranial nerve exams, how to do cerebellar exams, how to identify pathological reflexes. This could be like Conway Twitty or something. Past that. Okay, so when we think of these head direction cell networks, we have to think about the different receptor systems that feed into it. Let me go forward, then I'll come back. What do you think are some of the receptor systems that give our brain an awareness of how our head is aligned in relation to our trunk? Because that's ultimately what we're doing. We're trying to align our head with our trunk. So in scoliosis, this is important to us because if the trunk is disturbed, the alignment of the head will be disturbed with it. And that's why we co-manage as many cases as we can with an upper cervical doctor. And I work with Dr. Kelsey very closely with patients here in Clearwater. But understanding that there are sensory systems that feed up to the brain that give our brain an ability to write our head on our trunk is one of the things I wanted to share with you. And this is called the head direction signal. And basically, the vestibular system, which comes from your inner ear, your cervical spine, proprioceptively and otherwise, are going to create a reference frame for where your body is in space. And these head direction cells, and here they just show you in blue, the head direction cells are spread out throughout the entire neuraxis. So when you have an imbalance in your cervical spine afferents, let's say you have a loss of a cervical curve, or you've got a laterality of the atlas, that will feed up disafferented information to the brain, and when the brain is processing that, it will create a change in output into the motor systems. And so if a patient has an imbalance, let's say a loss of cervical curve, and they have a vestibular imbalance, which might manifest as dizziness or vertigo or even dyslexia, and you only correct one of them, you'll still leave imbalanced information feeding up to the brain. So this creates a bit of a problem for a practitioner who is only intervening in one way. And it might be important to think about when you're adjusting patients, if you're adjusting them seated, kneeling, side-lying, prone, dynamically versus statically, so moving the head or not moving the head, because all of those inputs will have a different consequence to these systems. And so sometimes we see patients get better on the setup, right? We lay them down and we go to adjust them and they already feel better. And that happens because when you lay a patient down, that's a vestibular activation. When you put pressure on their spine in one way or another, that's an activation of receptor systems. So that may be enough to change the input going into the higher cortical centers, and it may be enough to improve that patient's quality of life. And again, this is why a technique that creates a cavitation of a joint can be effective, and so can one that uses a vibratory activation. They both are activating receptor systems and maybe doing it differently, and that's why sometimes adjusting a patient face down might create a different outcome than adjusting them side lying. All of them have consequences centrally. This is the insular cortex. It's the forgotten cortex. The insular cortex is where all your sensory information comes in and is processed, and then motor changes are made from that to the hypothalamus and to the motor tracts. So the insular cortex is one of the most important cortex for the chiropractor. And I like to think of it as the forgotten cortex. What other receptor systems feed in to a patient's awareness of where they are in space? There's proprioceptive systems, there's vestibular systems, there's also visual systems. So we can look at patients' ocular alignment as well, and their ability to track and smooth pursue, and we'll talk about that on my next hour, are very, very important for those systems to have appropriate gain and appropriate function. And if they don't, that might be something that will help improve the case outcome. So here are the thalamic head direction cells, and we know the thalamus is the relay center for all of the sensory information that comes up from the periphery, are influenced by both external and internal sources of information. Although external cues exert strong influences on the anterior cells, the observation is that head direction cells are strongly influenced by internal sources of information. So that means that includes upper cervical imbalances. So if you have a patient with an upper cervical imbalance, that is going to strongly influence the head direction cell network. They're not going to have the ability to right their head with the horizon and with gravity. And so does the vestibular and proprioceptive systems. And the motor efference is the cerebellum's check on our ability to move. And so when we create a movement, our corticospinal tracts activate the muscles, then our cerebellum gets feedback about if that movement happened the way we wanted. That's called the motor efference. That's the kind of the checks and balances of our cerebellum. And so when you have a patient who goes to touch finger and nose and misses, and then goes to touch finger and nose and is accurate, that means their motor efference copy is intact. If they can't ever correct it, you're dealing with an ablative lesion, you're dealing with probably a medical concern, maybe a stroke or something of that nature. But if they correct, that doesn't mean that the first pass where they were imbalanced is inconsequential. It tells you that the cerebellum did not code well for the angulation of those joints to create the motor output that they wanted, but that they had the ability to motor learn. So this is a good thing, and if your patients have the ability to motor learn, obviously as you're creating changes to the input systems up to the brain, we're going to have the ability for that patient to get better. Another interesting thing about the insular cortex, it's also where we code for pain. So when we have patients that have deficits of any of these receptor systems up to the brain, we have the likelihood that they will be in pain as well. And so sometimes when we intervene by doing a vestibular stimulation, we can get a patient to experience reduced pain. If you rub something that hurts, you tend to override that pain, those pain fibers. This happens at the cortical level, right? Pain, who feels pain without a brain? Nobody, right? So all of this is happening centrally in this insular cortex. And so understanding that they all confluence in one area will help you explain better to your patients who have pain syndromes. And those pain syndromes can be in the low back, and I'm sure you've experienced this, and you don't touch their low back, but you change that pain syndrome. Well, how does that happen? Well, it could happen because you might have moved compression off of the spinal thalamic tracts because maybe there was cord compression, but it can also happen because you change the way the brain is integrating all of these sensory inputs. So don't limit the explanation of what you're doing and look at these things in a more global way, and I think it serves us all in the profession. That's the section through the middle of the brain here, and here you can see in the green, blue, and brown, that's the insular cortex. It's hid deep in the brain. It's not visible from the surface of the brain. Again, I call it the forgotten cortex. Any questions? You guys sleeping? See if there's anything else interesting in here. I'm going to show you how to evaluate otolithic function, vestibular function. You know how to look at somatosensory function. And yeah, so I hope that serves you guys well.
Thank you.